So we're going to go ahead and start with chapter 23, and hopefully you can see my screen. If you're not, for whatever reason, please let me know so I can fix it. So we're going to do neuro conditions, sensory neuro conditions, and then we'll do a little Kahoot, and then we'll do the musculoskeletal, and then we'll do another Kahoot. So within this category of sensory and neuro, we have included otitis conditions, both otitis media and otitis externa. So otitis externa is just an infection of the ear canal. It's also known as swimmer's ear. So otitis media is deeper, kind of on the other, it's on the other side of the tympanic membrane, so into the middle of the ear. And otitis externa is, it's literally just the ear canal. So there's pain and tenderness when you're manipulating the pinea or the tragus. So that's when you're talking about when you're manipulating the outside of the ear, it's painful to the ear canal. But the tympanic membrane is normal. So if you look in the ear, you're not going to see like bulging or discoloration of the tympanic membrane. And it's usually just treated, you irrigate the ear and you can put in some topical antibiotics into the canal. And you want to try to avoid, having water stay in the ear. Versus otitis media is actually an infection in the inner part of the ear, the middle ear. And then it does end up causing changes to the tympanic membrane. So this slide on the right-hand side of your slide, I guess left hand if you're, no, right hand, is going to show, it's red, it's bulging. So normally the tympanic membrane is like a pearly gray color. And when you have an infection, it gets beefy red and you can see it kind of bulging out. And that bulging is once there's fluid behind the eardrum. So the eustachian tube is a tube that helps drain fluid. It protects the middle ear and it equalizes pressure. And kids are at a higher risk for otitis media because their eustachian tube is shorter and it's wider. So they are at a setup for getting an infection into their middle ear because of the size and shape of their eustachian tube. So usually if a kid gets an otitis media, it's usually after they have a cold or an upper respiratory infection. It can be both viral and bacterial, and some common bacterial are streptococcal pneumonia and Haemophilus influenza, or Hib. And in addition to the changes in their the size and shape of their eustachian tube, they still don't have the same immune system as an adult. So that's just another reason that they're a higher setup for otitis media. So as a pediatric nurse, you will likely see kids that have ear infections. So it's really important to be able to see or to be able to recognize what an ear infection, how it presents, what kids look like. So this kid in the picture, he's pretty classic kid with an ear infection. It's painful. They tend to roll their head from side to side, or they kind of want to rub their ear, or they kind of cup their ear, or they put their fingers in their ear. So those are all signs: pulling, rubbing. Sometimes they just have behavior problems, like you don't really know what's wrong, but they won't listen to you. They won't pay attention to you. It can cause hearing problems. If they get repeated ear infections, they can end up with speech problems or hearing problems. So it's important to pay attention and get them the treatment that they need so they don't end up with any long-term consequences. So the treatment, if they suspect that it's bacterial, the treatment is going to be with antibiotics. Sometimes sometimes pediatricians will wait like 48 hours to see if the symptoms improve on their own, because there is a risk for bacterial supergrowth, or like developing bacteria that are resistant to antibiotics if they prescribe too much. So sometimes they'll prescribe an antibiotic and tell parents to fill it if the child's not feeling better within 48 hours. But if if it's high fever or the kid is really uncomfortable and they go ahead and go right to antibiotics, it's really important that the parents know to finish the full course of the antibiotics. They don't stop giving the antibiotic when the kid starts to feel better. That is also a setup for developing bacterial resistance to antibiotics. And sometimes kids will end up needing tubes placed, tympanic tubes placed, to help them prevent them from getting recurrent ear infections. And this is just kind of mentioning that to prevent reoccurrence, they really need to administer the full course of the medication even after they're feeling better. So this is just kind of reiterating, if it's a 7-day course of antibiotics and they feel better after 2 days, they need to keep taking the antibiotic for the full 7 days. So children can have hearing impairment. It can be related to otitis media or can be a completely unrelated phenomenon. Children are tested at birth for hearing, but even though they're tested at birth for hearing, as a nurse, you still need to have that in your back pocket as something that you're thinking about that could be going on with your child if they're not learning to speak normally, if their speech is not, it doesn't really make sense, or if they point a lot, they're not verbalizing when they would normally verbalize. Then you need to be thinking that they could have a hearing impairment. And there's different things that we can do to help communicate with kids that have hearing impairments. The main thing to remember is that just because they can't hear normally, it doesn't mean that they're cognitively delayed. So never assume that a child that has a hearing impairment has any sort of mental problem or mental incapacity in any way. They can frequently are completely normally intelligent. So you should treat them as a 10-year-old, even if they can't necessarily hear. And then, get down at their level, speak where they can really see you. Don't over enunciate or use a lot of facial gestures, because that can make it harder for them to read your lips. But speak in short sentences, make it easy to understand them as much as possible, and try to remember to treat them as their normal developmental age. And don't assume that they are less intelligent because they have a hearing problem. So this is going to kind of reinforce that, be at eye level with them, maintain face-to-face contact, talk in short sentences. And this is what I was talking about. Avoid exaggerating face or lip movements. That actually makes it harder for them to understand you if they're trying to read your lips. So those are the main sort of hearing, and since this is sensory and neuro, so the ear infections, otitis externa, otitis media, and then hearing loss. So we're going to move on to eye problems. So a common eye problem in children is a condition called strabismus. And kids that have strabismus, they squint a lot, like they're having a hard time focusing. They might cover up one of their eyes, and they see better when they're covering up their eyes, or they'll tilt their head to one side. So when they have strabismus, they don't have like normal nerve movement of one of their eyes. So if it's found early, what they actually do is they patch the good eye. So if they have a problem with one of their eyes, they patch the good eye, and that forces them to use the bad eye. So that'll strengthen the muscles in their bad eye. So that's the ideal situation, and it's found early enough in like early childhood or in infancy, so that they can still just patch the ineffective eye. And then if that doesn't work, they can prescribe glasses and do some eye exercises to help overcome the problem. And the worst case scenario would be surgery, but almost always it's going to be fixed with a patch, and the patch goes on the good eye, or glasses and eye exercises. So in addition to strabismus, kids can just have eye strain. They can just, their eyes can get tired from doing their homework or looking. So if they have eye strain, they really need to have their vision checked to see if they need glasses. So eye strain in kids is going to be, it's very similar. It's the same thing as an adult. So squinting, short attention span, they could have frequent headaches, difficulty with schoolwork. All of this would be an indication that their eyes are getting tired, that they're straining their eyes to see, and they need their vision checked, and they might need glasses. So a cancer that is possible in childhood is something called a retinoblastoma. So this is a cancer of the retina, and it is a malignant tumor. And these are some pictures. You have this yellowish white reflex seen in the pupil. So it's this one here and this one here. And it's usually accompanied by loss of vision and pain. So it is a treatable form of cancer. So laser photocoagulation therapy, chemotherapy, and the worst case scenario is they would actually have to remove the eye in order to remove the tumor, but that is not common. Usually responds to less invasive therapy. And then this is just to go back. This is, you're looking at this, everyone where you have that whitish yellow, that's the retinoblastoma. So we can learn a lot about looking in kids' eyes. So something you always need to be paying attention to are what are your medical emergencies. So if you ever see fixed and dilated pupils, so pupils that are bigger than normal and they're not reacting to light, they're the same size and they're not changing, that's an indication of increased intracranial pressure. So there's being pressure put on the cranial nerve because there's expanding pressure in the brain. So that's a medical emergency. If you ever see that in a patient, you need to be concerned that they have increased intracranial pressure. So we're going to move on from the sensory and start talking specifically about neuro stuff. So altered level of consciousness is something that we talk about a lot when we're talking about anything related to neuro symptoms. So there's a couple different things that can cause altered level of consciousness. So a change in either your oxygen level or your carbon dioxide level. So these are giving very specific parameters: a fall to 60 or below for your PaO2, which is going to be your oxygen, or a rise above 45 of your PaCO2, which is in your carbon dioxide. But I would say more than memorizing that specific number, to just recognize like changes in either direction. You know, a change in your oxygen or a rise in your carbon dioxide. So this is getting to your respiratory. If you're having a fall in your oxygen, you're not having good oxygenation, you're not breathing effectively. And the same is true. If you're not able to exhale effectively, your CO2 is going to go up. So both of these can cause an altered level of consciousness. So can low blood pressure or a fever. Taking specific drugs like sedatives or anti-epileptics. A seizure is very common. When you have a seizure, that you have what's called a post-ictal state, where you're really sleepy when you're coming out of the seizure, or increased intracranial pressure. So you do not need to memorize this for the test, but this is a good review of the different neurological nerves. So the 12 cranial nerves. And a lot of times the name of the nerve kind of tells you how you would test for it, right? So olfactory nerve, so your ability to smell, you would test that by giving them something to smell. And the optic nerve, you test the optic nerve by having them see. Ocular motor, by checking their movements of their eye. So this slide is a good review of the 12 different cranial nerves and a basic indication of what those nerves do. Like I said, you don't need to remember all 12 of them. There are some that I think are a little bit more important, like the number 8, the acoustic nerve, is the nerve that you need to hear. And then number 2, the optic nerve, the sight. These are some bigger nerves. The vagus nerves is important because you can have like changes in your heart rate if you have stimulation of your vagus nerves. So I would generally recognize, that there are 12 nerves and be able to, like I said, usually the name of the nerve tells you how you would test for it and what that nerve does. This is an acronym to help you remember all of them. 001 takes the anatomy final. A good vacation seems heavenly, where every letter of the sentence corresponds to the first letter of that cranial nerve. So there is something called Reye syndrome. Has anyone ever heard of Reye syndrome?
That's when like a pregnant woman takes aspirin.
Okay, so it does involve aspirin. It doesn't have to be a pregnant woman. So it's associated with a viral infection and aspirin use. Does anyone know the medication category that aspirin falls into?
Yeah.
NSAID.
So it's a salicylate, very, very close. So sometimes when you're being tested on, whether on Rye syndrome, you might see salicylate, like medications in the salicylate family, instead of the word aspirin. So I would recognize it, and I can put it in the chat if you guys are unfamiliar with what I'm talking about. Oh, sorry, I tried to send it to just one person and obviously didn't go through. So there you go. So the salicylate is the medication family that aspirin is in. So Rye syndrome causes neurological symptoms, and it's associated with having a febrile viral illness and taking aspirin. So this is one of the reasons why we recommend Tylenol is usually the first line if kids have a fever. You definitely don't want them ever taking aspirin, because aspirin or the salicylates, that's the only medication in the class that's associated with Rye syndrome. So it causes neurological symptoms like lethargy, like weak vomiting. They just kind of they're kind of weak and floppy, and they vomit. It's not rare. Most people know not to give aspirin to kids, but your overall nursing goals are to make sure they're not having an increase in their intracranial pressure. So monitoring their level of consciousness, making sure their airway is patent, making sure they have adequate oxygenation. And since they are at risk for vomiting, making sure they have stable food and electrolytes. So this is this slide has salicylates written for you. So discourage the use of aspirin or other medications that contain salicylates. And it's, like I said, it's associated with those medications and a febrile viral illness or flu-like symptoms. So something called meningitis is another neurological problem. Does anyone have can anyone sum up what meningitis is, or what children look like if they have meningitis?
Infection of the meninges in the brain and spinal cord.
So so infection of the meninges, inflammations of the meninges, and what is the meninges? So it's the membrane that covers the brain and the spinal cord. So it is kind of important to remember, because it's not like deep in the brain tissue. It's not like an encephalopathy where it's the brain tissue itself that's infected. It's the membrane that surrounds both the brain and the spinal column. And so meningitis is inflammation of the meninges. So sometimes you can have what's called aseptic meningitis, which is like meningitis that's not caused by an infection, but it's usually infectious, and it can be both viral or bacterial. And you can really be quite sick with meningitis, fever, headache, vomiting, very, very sensitive to light. They can have altered level of consciousness. They can be confused. You worry about, it can, like in worst case scenarios, lead to increased intracranial pressure. So there's something that we refer to as Cushing's triad. Has anyone heard of Cushing's triad? In any of your other classes, have you talked about Cushing's triad? If you haven't, I'll tell you. So Cushing's triad is one of the things. Oh, I spelled it with a B. It's with a K. Sorry, my fingers are fat. Cushing's with a K. Oh, it does. It keeps trying to autocorrect me. Oh. Well, Cushing with a K is so an irregular respiratory rate, an irregular breathing pattern, bradycardia, and hypertension, and or a widened pulse pressure. So those three things together are a very ominous sign, and it's an indication of increased intracranial pressure, and that those three symptoms together are referred to as Cushing's triad. So if you're ever asked a question about something that is a medical emergency, you're doing a neurological assessment and you notice a vital sign change, for example, in a patient that you're doing a neurological assessment on, if there's a vital sign change that's consistent with Cushing's triad, that's the one that you're going to focus on, because vital sign changes that are consistent with Cushing's are an indication of increased intracranial pressure. So there's a couple of different tests that we do to try to, that are useful in trying to figure out if someone has meningitis. So the first one is Brudzinski's, and Brudzinski is this kid here on the left-hand side, where you bend his knees and you flex his neck. They end up with neck stiffness when their hips and knees are flexed. So it's more difficult to bend their neck forward when their knees are bent. And that's Brudzinski. And the other one is Kerning's, and you see the kid laying down there. And it's the inability to straighten the leg when the hip is flexed to 90 degrees. So his leg is at 90 degrees and he can't fully straighten his leg out, and that's a positive Kernig sign. So neither one of these are definitive for meningitis, but they are commonly used and tested for if you're suspicious of meningitis. And does anyone know, like, what would be definitive? How would you definitively say this kid has meningitis? What type of tests do you do? Has anyone heard of a lumbar puncture? No one's heard of a lumbar puncture? What do you think they do during a lumbar puncture?
They take fluid from, I guess, from your spinal cord.
Yeah, so they put a needle into your spinal column, and they take in the fluid that comes out is your cerebral spinal fluid. So they drain some of your CSF. And then they send it to the lab, and they're looking for white cells is the main thing. So you should not have white blood cells in your CSF. So, you know, an elevated white cell count in your CFS is an indication of meningitis. And they also send it for culture and sensitivity. So that is the main way that they definitively determine that someone has meningitis. So if you're a nurse and you're caring for a child that has meningitis, you need to kind of be thinking about things that you're going to be doing. They're going to be in droplet isolation until they have, identified the appropriate antimicrobials. They've got their cultures back from their CSF, blood and urine, whatever cultures they sent, and that they're on, they're on appropriate antibiotics. And you're going to do frequent neurological checks. Like I said, they can have increased intracranial pressure, and you want to report any findings like weakness of the limbs, speech difficulties, any confusion, behavioral problems. You want to do a very accurate recording of vital signs and intake and output, and you want to have a nice quiet environment with not a lot of stimuli, because things like light can be very annoying to them. Okay, so we're going to move on from meningitis to seizures. Has anyone known anyone that had a seizure disorder? Have you ever seen anyone have a seizure? Does anyone have like a child or a cousin or anyone like that in their family that has seizures? No? Who can describe what a... Go ahead.
I was saying that my brother has seizures.
Okay, and what do her seizures look like? Or has he not had one in a long time because he's on his...
He just had like the past year or so.
Okay.
And it's kind of a little weird to see he has them when he's sleeping.
Oh, okay. So there's lots of different ways that seizures can present. Like the biggest is going to be called like a generalized tonic-clonic seizure, when they fall down and it's jerking and convulsing of both extremities. But they can also be very subtle. It can be like an eye that's twitching or a hand that's twitching. or they can even be something called absent seizures, where they just kind of like lose their train of thought for a few seconds and they come back. So it's abnormal electrical eruptions in the brain that causes the seizures. And there are certain things that kind of are triggers, startling movements, overhydration, bright lights, or flashing lights. All of these things can be triggers for seizures. What do you think are some things in the medical world, like what might trigger a seizure in someone that didn't previously have a seizure? Is it always epilepsy, or can other people have seizures?
Infection.
Infection. So people with meningitis can have seizures. How about blood sugar? What do you think? Is there, can having a low blood sugar cause you to have a seizure? So it can, so really severe hypoglycemia can cause you to have a seizure. Like you said, infection, meningitis, which is obviously a form of infection, electrolyte imbalances, people that have sodium imbalances can have seizures. So it's not always because they have a seizure disorder. There are certain like physiological problems. Certain medications can cause people to have seizures. So for a patient that has a seizure disorder where they have epilepsy, there's going to be a pretty wide diagnostic workup. And then they'll try to figure out like the area of the brain that is causing the abnormal electrical activity. And then they will choose an anti-epileptic. This is going to, be treating, where the electrical activity is and the type of seizure. And then they need to be monitored, and they might need to have their dosage corrected as they grow older. There is a specific seizure medication that's frequently on NCLEX questions called Dilantin. Has anyone heard of Dilantin? It's also called phenytoin. Okay, so Dilantin is used frequently, and one of the things that it causes what's called it causes hyperplasia of your gums. So it can cause like beefy red gums and bleeding gums. So it's a common thing to test on because it's not very many patients have that side effect. So they teach parents to rub the gums of their children to kind of prevent that hyperplasia. So when children have a seizure disorder, it's best if they're part of a multidisciplinary team, primary care provider, their neurologist, and then any sort of specialists that they need in terms of OT and PT to making sure they're staying on track and able to meet their milestones. There are certain things, if you're taking care of a child in the hospital and you have seizure precautions, you want to always make sure that the side rails are up, that they don't have access to any sharp objects around the bed, that they always have their ID band on. That's true for all patients, but if you have a seizure, you need to be able to give medications quickly. You want to avoid triggers, and you want to make sure that you're teaching parents the importance of compliance, or making sure they take their anti-epileptic medications as ordered. So there is possibly I'm sorry, I moved ahead here and I got confused. I'm sorry, I was not expecting this slide, so it took me a minute to figure out. I thought we were talking about botulism because it said botulism on there, but we're moving on to CP. So I apologize that my brain got sidetracked here. So cerebral palsy is a neurological condition that you'll see in childhood. It's most commonly associated with anoxic brain injury. So there's something wrong during the birthing process. They don't get enough brain or enough oxygen to their brain. It can also be something in utero. They can have intrautero stroke. So there's a problem with their brain development or their spinal cord development when they're still developing. So they tend to, I'm sure, has anyone known a child that had CP? Can you kind of summarize what CP looks like in a kid? What do you think about when you say that somebody has cerebral palsy or CP? What do you think do they walk normally? Do they not walk normally?
Is that when they kind of walk funny with their knees bent and their arms are kind of frailing?
So yeah, so they tend to be pretty stiff. Like they tend to walk on their toes. They can't get their feet flat, so they tend to walk on their toes. Sometimes they have those special crutches that they use. They don't have a normal gait, and they frequently kind of have like fingers like this where they need adaptive devices to help them eat. So it is like a full body neurological problem where they don't have the same coordination or muscle movement. There can be CP with mental retardation. It is associated with mental retardation, but you can just also have kids that have CP and neurologically, mentally, they're fine. So there's like a term that's called MRCP, which is mental retardation, cerebral palsy, and then there's just CP. So, but it is, damage to their spinal column because of lack of oxygen, either in utero or during birth, and then they have problems walking, feeding themselves, dressing themselves, etc. And it can also be associated with mental retardation. So if you're working in pediatric hospitals, you will see kids that have CP. They come in all the time. Sometimes they really have a lot of mobility problems, so then they're at risk for like pneumonia or respiratory complications because they can't cough and deep breathe, etc. So you want to, try to meet them at their level. Don't assume they're mentally retarded because they have CP. There's a lot of communication boards. They have like boards where the kids can point with their eyes towards in a specific direction to indicate yes or no, and it lights up the answer on the board. They have special wheelchairs that they can control with very minimal movements to help them get around. So they have a lot of adaptive devices to help kids with CP interact and move and socialize as much as possible. So always try to maximize their ability to interact with you and with the rest of the healthcare team and with their family, because like I said, sometimes there can be mental retardation, but sometimes it's like their body doesn't work, and they need a lot of help to move and communicate. So like I said, CP can be associated with mental retardation, but it's not always. So when you're talking about intellectually impaired children, you still want to try to meet their psychosocial needs, but just remember that they might not be able to express themselves in the same way. So it takes a certain, you have to kind of slow down, see where the kid is, get down at their level, and then try to communicate with them and help them communicate with you. And never, if they're able to communicate, you don't want their parents to communicate for them. You always want to try to give them the best chance they can to communicate for themselves, so they still develop that sense of autonomy that you would want in any child, but it might take them longer. They might need some additional help in order to do that. So, if they have an intellectually impaired child, they might need more support. The family might need support. You really want to encourage the parents to focus on their strengths instead of their weaknesses. And just always remember, if a kid's constantly being told that he's not good at something or that he's failing at everything, that can make them angry or ultimately have them develop behavioral problems. So in terms of, providing care to the children when they're in the hospital, always thinking about family-centered care, putting the family in the center of everything, giving the kid the emotional support that he needs, and helping them with any sort of adaptive devices or communication boards or whatever they need to be able to tell you what's going on. And try to always, implement the home routines as much as possible while maintaining a safe environment. So, there's physical problems, there's mental problems, and then there's disabled, they can't move at all, they're wheelchair bound, etc. So always try to, regardless of what's going on with the kid, always try to focus on their strengths, always really maintain good communication with the family, and have good communication with the school nurse or whatever sort of social work organizations are working with the family, and try to make it as likely as possible that the kid will be able to participate in activities that are age appropriate and have like many of the same experiences of other kids that, you know, aren't wheelchair bound, et cetera, and kind of know your local your local resources in terms of support groups and stuff like that. So, you know, sometimes children will have a normal facial appearance and they can be mentally retarded, or children can have an unusual face and they're not having any problems. So don't always assume that what they look like determines what their intelligence level is. There's obviously some, for example, Down syndrome. It's, you know, you look at somebody and you're like, oh, they have Down syndrome. So there are some conditions where, like Down syndrome, that you can kind of look at them and you can know, but don't assume anything based on what somebody's facial expressions are, or their facial, what their face looks like. So kids can have, you know, neurological problems, short-term, hopefully following sports injuries, et cetera. So the most common one would be like a concussion. So one of the things that you worry about, if it's a concussion with amnesia, or they don't remember the event, that's a more serious type of concussion, and it is an indication that maybe they have a fractured skull. So you need to pay attention if they fell and they don't remember that event. That would be something that you would need to follow up on and potentially get them more diagnostic imaging to see if it was a more serious event than you thought. So when you have a head injury, it can cause increased intracranial pressure, cerebral edema, and they're also a setup for an infection. And all of this can happen within a few days of a head injury. So hypoxia, or lack of oxygen, yeah, you know, the brain requires a lot of oxygen. There's a lot of cerebral blood flow that goes to the brain. So if you have a low oxygen level, that can cause problems because your brain consumes a lot of your oxygen. And when you have increased blood flow, like if you have a low oxygen level, you'll have increased blood flow to the brain to compensate for the fact that your blood oxygen level is low, and that can lead to cerebral edema. And then cerebral edema can lead to increased intracranial pressure. So pay attention to all those things, and always sort of know what signs of increased cranial pressure are, and to be on the lookout for them so you can intervene. There's some basic things that you might see following a concussion. So like headache, dizziness, balance is slightly off. They can feel kind of foggy. They can have inability to pay attention. They may be a little bit sleepier. Like I said, if they don't remember the event, if they have amnesia after they've fallen and hit their head, that's an indication of a more serious event that needs further evaluation. So unfortunately, whenever we're talking about pediatrics, we have to think about child abuse. So something called shaken baby syndrome. Has anyone heard of shaken baby syndrome? The word,
Yes.
the phrase kind of gives it away. So what do you think shaken baby syndrome is?
Is it when they're shaking the baby and their spinal cord detaches from their brain?
So it doesn't have to necessarily detach, but they can have, you know, cerebral edema. So you think about the brain being inside the skull, it can move back and forth. It doesn't have to necessarily detach from the spinal column, but it causes brain damage, and they can have bleeding. It can lead to long-term problems like, you know, mental retardation. You can even die from shaken baby syndrome. So one of the main things that you'll see is subdural, or I'm sorry, you'll see like blood in the eye. You'll see, like, because they're shaking and then it bleeds, and you can actually see that in their eye. They can also have what you talked about. She talked about like the spinal cord detaching. So you can have high level spinal cord injuries, high level being, you know, where the spine meets the brain. So there's a wide range. Like I said, it can just be like headache, fussiness, all the way to life-threatening, deadly brain damage. But so being drowsy, vomiting, these are problems that could be associated with shaky baby syndrome. So if you have a kid that like comes into the emergency and they're vomiting a lot and they seem kind of they like, usually when kids they have like a viral GI bug, they're irritable and they're vomiting. But if they're like really sleepy and they're still vomiting, that's a really serious something that you should be really worried about, because those things go to, in that combination, more of an indication of like a neurological problem. So they can also become completely comatose. They can actually die. So what do you think that we do? How do we, what do we tell parents to do if their baby's screaming? What's like an anticipatory guidance or something that you teach parents? If their kid is screaming, 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 and the parent's getting so frustrated, what should the parents do? Those of you that are parents, what have you done when you were just going to lose it? Kid would not stop crying. Has anyone been around a baby that was screaming his head off and was just wouldn't stop crying? What did you do?
Provided them with comfort, like pick them up, rock them, and stuff like that.
Yeah, so you can certainly start with that. The main thing is, if you really feel like you're going to lose it, it's better to put them in a safe place and take 5 minutes and walk away. Like if you're to that point that you're like, I'm going to pick this kid up and I'm going to shake this kid because I'm so frustrated, it's better to just put the kid down, put him someplace safe, and walk away for 5 minutes so they can get a deep breath. So maybe you need to call for help. Maybe you need to go to your neighbor's house and just be like, I just need a few minutes. But the main thing you want to teach parents to do is you never get so frustrated that you just pick the kid up and shake them. So sometimes when you have a brain injury, the patient will come in with specific posturing. So decorticate is when the arms are in like this. And I always remember this as to your core. So to your, in towards your body is decorticate. And deceberate is like your arms are out like the E. So if your arms are in the decorticate, that's a problem with your cervical spine. And if they're out, it's more of a problem with your midbrain. So this is just a way when someone comes in, if they're posturing, it's a bad sign. It's never a good sign to someone, either for a patient to be posturing. This is a way for you to try to figure out where they've had a neurological injury. So when you're doing a neurological check, like I said, you're always going to be worried about increased intracranial pressure. So level of consciousness, pupil and eye movement, vital signs, and motor activity. So, increased intracranial pressure, you're going to have a decreased level of consciousness. Pupil and eye movement, like I said, fixed and dilated pupils, that's a sign of increased ICP. Vital signs. Who remembers what Cushing's triad is and what sort of vital signs you might see? I'm going to give you a hint. It's on the corner here on the right where my mouse is.
Oh, yeah. The increased blood pressure and decrease in pulse.
Yep. And then an irregular respiratory pattern. So drop in heart rate, increase in blood pressure, and irregular respirations. And do you think they have normal motor activity when they have increased ICP?
No.
No. So kids are higher risk in general because they can't really communicate necessarily as easily what's going on. So you need to be extra observant with kids and remember the nurses are the front line. You guys are lifesavers. So paying attention to subtle clues can give you an indication. So, if the blood pressure is another thing, like if the blood pressure goes up, that's not, usually when kids are getting medication, if they're in the hospital, you wouldn't actually expect their blood pressure to go up. And then if their blood pressure goes up and their heart rate goes down, like you really need to pay attention to that. You need to pay attention to those changes in vital signs and really intervene early, because that can really help save the child's life. So there's a couple different, things that you're going to be paying attention to when you're doing assessment of neurological assessments in children. We've talked about most of them. We didn't talk about bulging fontanelles. So we're talking about before the sutures fuse in the kid's head. And what do you think a bulging fontanelle is? Why might that happen?
The CSF fluid is building up.
Yeah. And so since their sutures haven't closed, they have the ability to kind of go up like that. And then ataxia, they're not able to walk normally, they have some spasticity. Those are all things that would be unusual that would be included in your neurological assessment. How about sunken fontanelles? Why might a kid have a sunken fontanelle?
Dehydration.
Dehydration. So the last thing that we're going to talk about in this section is drowning or near drowning. So near drowning is the fourth leading cause of death in children under 19. And near drowning is defined as survival beyond 24 hours. So after a submersion, and you know, the things you're focused on is hypoxia or lack of oxygen, aspiration with damage to the lungs, irritation of the lungs, and then hypothermia or their body not being able to maintain their temperature. And you know, the main thing that you worry about if they survive the drowning is CNS injury long term. So if they are submerged for more than 10 minutes and they don't regain consciousness as at the scene or within 24 hours, that's an ominous sign that they're unlikely to survive the event. So what are some things you do as a nurse to help prevent against near drowning or drowning? What are some things that you teach parents?
Swimming lessons for their kids, teach their kids water safety.
Water safety. What's another thing? Kind of makes sense, but you know, what do parents do? I mean, water safety for the kids, but what do the parents need to do for water safety?
Put them at all times.
Yeah, and if you have, you know, if you're at an apartment complex where there's a pool, paying attention, is there a fence around, and just always having your eye on them. Teaching them to swim is really important, but you know, also taking steps so they never fall in is equally important. All right, so I'm going to pull up the Kahoot really quick. We'll do a quick Kahoot and then you guys can go on a break. Let me log in here. Okay, we're gonna go ahead and get started here. It's only 9 questions and you guys can go on a break. Why are infants more susceptible to otitis media? The eustachian tube is short, straight, and wide. Infants are always lying down. They have increased susceptibility to upper respiratory infections, or sucking on a nipple creates middle ear pressure. Yeah, so it's the short, straight eustachian tube that makes them a higher rate, higher susceptibility. A student has a generalized seizure in the school nurse's office. At what point should the nurse call 911? The child is sleepy and lethargic after the seizure. The child vomited at the onset of the seizure lasted more than 5 minutes, or the child is confused and has slurred speech after the seizure. Okay, so the child has a seizure that lasts more than 5 minutes is the correct answer. So the child, is normal for them to be sleepy after the seizure. It's somewhat common. They're going to vomit at the onset and the child is a little bit confused. All of those things are normal things that you typically see with a seizure, but it is not normal for a seizure to last more than 5 minutes. So if this is happening, then you need to call 911. You need to be worried about their airway. They might need to be intubated. So what would the nurse include in a teaching plan about the long-term administration of phenytoin or Dilantin? The medication should be given on an empty stomach. Insomnia can be a significant side effect. Gums should be massaged regularly to prevent hyperplasia, or blood pressure should be monitored closely. Right. So this is the one that we talked about. It causes the hyperplasia of the gums. You kind of massage that to help them not develop that hyperplasia and the bleeding gums. What assessment finding in a child with meningitis should be reported immediately? A slight drop in blood pressure, irregular respirations, tachycardia, or an elevated temperature. All right, so we talked about Cushing's triad a couple of times. So what happens to your heart rate when you have increased ICP? Does your heart rate go up or down? Somebody mouthed it. Kendall, do you remember what happens to your heart rate when you have increased? Your heart rate increases when you have increased intracranial pressure?
I'm sorry, it's the opposite. Your blood pressure increases, heart rate decreases, and you have irregular respiration.
Very good. Thank you, Kendall. So this is the one. This is, of all the things that are on this here, the blood pressure drop, your normally pressure would go up with increased ICP. Tachycardia, your heart rate goes down. Elevated temperature, not associated with ICP. So this irregular respirations is that warning sign. If you're paying attention to your patient's vital signs, you're going to intervene early if you see this, because that is an indication that they're getting worse. So the nurse urges the mother of a 6-month-old child to get vaccinated against Hib. Why is that? Protect against otitis media, to protect against influenza, to protect against bacterial meningitis, or to protect against skin infections. This one I don't love. You guys overall got it right. It does also protect against otitis media, but the main thing that you worry about is the bacterial meningitis. So good job. What situation would cause the nurse to suspect a hearing impairment in a child? 3-month-old with a positive startle reflex, an 18-month-old who is speaking 1-syllable words, a 15-month-old who is babbling, or a 24-month-old who communicates by pointing. So it is the 24-month-old that communicates by pointing. So 24-month-old should really be speaking in 2-word sentences. So they should not be pointing to get their word. I mean, they might still point, but they should be talking. This should be their primary way of communicating. What is the best way for a nurse to communicate with a 10-year-old who has a hearing impairment? Let the child's parents communicate for her. Recognize the child will communicate at a 6-year-old level. Use gestures and signs as much as possible, or face the child and speak in clear, short sentences. Right. So good job. You want to look at them and make sure that they can read your mouth. Sorry, I moved my computer screen. You couldn't see me. What might the nurse explain as a common treatment of amblyopia? You know, I have to go back. We didn't talk about that one, so I'm not going to have you guys talk about that. Sorry. I'll make sure that I mention it when we come back. I apologize for that. What information should be given to parents to prevent Reye syndrome? Test the child for Reye syndrome if they exhibit fever, vomiting, and lethargy. Use aspirin instead of Tylenol. Encourage immunization to protect against Reye syndrome, or avoid salicylate medications to a child who has viral symptoms. All right, good job, you guys. That's the one. You avoid the salicylates to protect against virals when they have a viral illness or a febrile illness. All right, Blake, good job. James. Dun, 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 dun. All right, who's EC? Is that Eric? Erica, who's EC?
Yes, ma'am, that's me.
Ah, very good. Okay. So you guys can go ahead. Let me take a look at the time here. Took a little bit longer than I thought. So it's 4. If you can go ahead and come back at 4:10 and we'll get started, and I promise to get you guys out on time. Okay. Okay, everyone, so welcome back to class. When we were going over that Kahoot, I realized for some reason in the PowerPoint, amblyopia wasn't in there. So I wanted to make sure that everyone knows the difference between amblyopia and strabismus, because both of those are eye problems in children and you need to know what both of them mean. So strabismus is the one that we saw, it's that cross-eyed, where they don't have the normal nerve function for one of their eyes. So they have like an eye that's cross-eyed and you treat it by putting a patch on the good eye to strengthen the muscles of the bad eye. And then amblyopia is when there's one of the eyes has different vision than the other eye. So there's a visual acuity problem where one eye sees better than the other eye. And it's often treated the same way with a patch in terms of like forcing the bad eye to get better. And then they also will need vision correction. So the main difference between the two is that amblyopia involves visual impairment and the strabismus doesn't. Strabismus is just that problem with the nerves that the eye uses to move, where they end up cross-eyed, and then you put a patch on the good eye to help them strengthen the muscles of the bad eye. Does anyone have any questions about that? So the two words are strabismus and amblyopia. And the treatment, the initial treatment is really the same for both, in the sense that the patch is put on the good eye to strengthen the bad eye. But with amblyopia, it's to help with the visual acuity. And when strabismus, it's to help with the muscles that the eye uses to move, strengthen them. So we're going to move on to musculoskeletal problems in children. This is a really big PowerPoint slide. There's 70 PowerPoint slides, and we do not have time to go over all 70 slides. So I am going to jump around a little bit. I think I sent these to you. If I have not sent them to you, let me look. Then I will send them to you so that you guys have a study guide. I thought I sent them, but let me make sure. And then we will do a brief Kahoots, but I'm going to jump around a little bit and go to the things that I know are the most important. But it is a good reference for you for like a more comprehensive review. Let me go to my mailbox here. Yeah, okay. So if anyone didn't get them or they need me to resend them, let me know. But like I said, we won't go over all of them. I'm going to put alarm on my phone so I know when to start the Kahoots for you guys. Just a second. Okay, so when we're talking about kids and their musculoskeletal system, one of the main things to really think about is that kids are growing still. So, you know, they have rapid growth of their skeletal system, and they actually have some protection against breaking bones. They're resilient, they bend more than adult bones. They have more blood supply, so healing occurs more quickly. There is a term that you need to know. It's this I'm such a problem pronouncing words sometimes. Epiphyseal plate. So it's like here in the femur, it's the place in the bone that is responsible for regulating growth. So if they have a fracture in that area, it can affect the length of that bone. You know, the muscular and the skeletal system are related, so they can have problems with both. And if they have any sort of a deformity, it can get worse rapidly because their body is changing rapidly. So what sometimes parents will worry about how their kid walks. Sometimes kids kind of waddle. So children, actually, we'll go to the slide above this. They kind of have this wide, unstable gait, and that's normal, but sometimes parents worry about that. And then by the time they're about 18 months or a year and a half, they're walking more stably. And by the time they're 4, they can hop. By the time they're 6, they're doing the normal thing where they swing their arms. So if you have a parent that's worried about their child's gait, you know, most of the time it's probably going to be normal. So reassure them unless there's pain or something like that, that it'll get better with time. We did talk briefly in the last hour about something that you do worry about, and that's walking on toes. So if kids are walking on their toes and they never have their foot flat on the ground, that's a sign of CP that requires additional evaluation. So when we talk about soft tissue injury, we're talking about when you hurt yourself, but you don't break the bone. So this is going to be sprains, strains, and contusions are the 3 different types of soft tissue injuries. And there's a general acronym that we use to talk about what you do. So if we're not talking about a fracture, we're talking about a sprain, a strain, or a contusion. So this acronym RICE, rest, ice, compression, and elevation. So this is what you normally do if they've fallen and like twisted their ankle, but there's no fracture. So this is these are the 3 different types of soft tissue injuries. A contusion, you fall and you have a rupture of the blood capillaries. So you might see some bruising, discoloration. A sprain is twisting of the ligaments, and a strain is twisting of the tendons. So does anyone remember, what does a ligament connect? Does anyone know what a ligament connects? Or what's the difference between a ligament and a tendon? Someone was kind of mouthing it here. Erica,
Bone to bone and muscle to bone.
Yeah, so the ligament is bone to bone and the tendon is muscle to bone. So a sprain is going to be of the ligaments, and the strain is more of a muscular damage between the bone and the muscle. So that's, you might see that again in your life. That would be the difference between a sprain and a strain. So, you know, if they fall and hurt themselves, you want to stop what they're doing and do the rest, ice, compression, elevation. If it's not getting better, they might need an x-ray. Try to do anticipatory guidance, preventing injuries, and talking about safety equipment and stuff like that. Basic things that we talk about in terms of pediatric prevention of trauma, you know, car seats, and or seat belts, bicycle helmets, pool fences, window bars, locks on cabinet doors, all of those things that I think that we probably know, but you know, never assume that your parents know this and you're doing a good job of anticipatory guidance. So this slide here goes over the different types of fractures. I'm going to point out some that I know that you need to know. So for example, a spiral fracture, which is this one on the right on the top row. So this is like the bone goes like this and you twist it. And that twisting sensation is what causes the fracture. So this is commonly associated with child abuse. And if you think about it, that makes sense, right? Like when do you twist your bone? Like sometimes gymnasts can, if they're doing like a twist in the air and they land kind of, and they're landing as they're untwisting. But you know, if you think about it, like you take the bone and you twist it in 2 opposite directions, that's child abuse. So this is the type of fracture, if you're ever asked, that's most commonly associated with child abuse, is the spiral fracture. Other fractures that you know, you should be able to differentiate between. So like a simple fracture, you can see there's just this line here, but the bone is still lined up. There hasn't been any movement of the bone in any direction. The bone is still in alignment. Whereas a compound fracture is like broken and the bone is broken through the skin. This is not the best picture, but a green stick fracture is just a very, very slight fracture that's really, really hard to see. And it doesn't go all the way through. So you can see here the bone on the bottom is still in place and there's like a slight fracture through the top of the bone here. So those are the ones that I would pay attention to. And I would remember that the spiral fracture, where the two sections of the bone move in opposite direction. And this is the one that's most commonly associated with child abuse. So when we talk about fractures in kids, one of the sort of things that you're going to see in the hospital is traction. And I know that there are several questions on your test on traction. So there's there's 3 different types of tractions, but there's 2 main ones that we talk about: Bryant's traction and then Russell's traction. So Bryant's traction is the one that's for younger kids, so kids up to 30 pounds. And it's for femur fractures. And this is a picture of it here, where their legs are elevated in the air. And you can kind of see, I mean, you can't really see, but their butt is a little bit off the bed. So they're not flat. You're pulling their legs up to the point that their butt's a little bit elevated. And they might need like a jacket on so they can't pull at stuff. Like this is going to be younger kids up to 30 pounds. So you don't want them like moving with their pulley system or their weights or anything like that. So you might need to restrain them with a jacket. And you probably have talked quite a bit about restraints and neuromuscular assessments in med-surg, I'm going to guess. So what can you tell me? What are some things that you do as a nurse that you assess for when your patient's in traction? Does anyone know?
The skin,
The skin, what are you looking for on the skin?
any breakdown, necrosis, or any sores.
Yeah, very good. So, and then what color should the skin be?
It should be, moist and pink.
Right. So what are some things that are warning signs that you worry about, like either in the skin or in the extremity? Like what's not normal?
Any darkening of the extremity could signify, venous flow.
Okay, so yeah, very good. So you want to make sure that they have, when you chest like capillary refill should be around 2 to 3 seconds. So if it's delayed, that you're worried they're not getting good blood flow, if it's cool to the touch, if they're not able to move their toes. So any sorts of changes like that are things that you need to worry about. And for this Bucks traction, which is the traction for broken femurs and kids under 30 pounds, they need to be at a maximum of 20 degrees. So they can't be sitting up in bed with their legs up. They're going to be like this, laying down with their legs in the air. And this is some like acronyms to use. Not all of these really apply to the younger kids. Like for example, the trapeze. You can't really expect a 2-year-old to use a trapeze to move around in bed, but this is, an acronym to help you remember things that you're going to be thinking about when you're taking care of a patient that has traction. And in terms of, let me see here, I'm sorry, look here. So yeah, so Bryant's traction was the younger kid, and then Buck's traction, I'm sorry, Buck's traction is the one that's the older kid. And it's also, it's also, for the leg, but you can see in the picture, it pulls the leg in 2 different directions to move the bone together. So you see it pulling it in both directions like this. And the main purpose is to reduce pain and muscle spasm. And it's the same thing where they're going to have weights, etc. So in terms of remembering the main difference, so the little kid traction is the Bryant's traction, and then the older kids traction is the Bucks. So you do need to know both of these for your exam. And some common things is that the bed should not be elevated. The weight should never be on the floor. The pulley system should be in place. So Bucks and Russell are very, very similar. So I'm not going to really go over Bucks, but so Bucks and Russell are both for the older kids over 30 pounds. And then Bryant's traction is the one, it's for the kids under 30 pounds. It's for a femur fraction and their legs are elevated in the air. And for whatever type of traction they're in, you're going to be doing neurovascular checks is the main thing that you're going to be doing as a nurse. And then making sure their bed's not elevated. And making sure that the weights are free flowing. So the basic things that you need to know for all types of traction. And then I think it was Erica that mentioned, you really be paying attention to the skin. So for adults, I'm going to pull up this slide here. They use skeletal traction where they put the pins into the bone, and then you really do need to be paying attention to the skin. A lot of time for the kids, they use what's called skin traction. So they put something adhesive like tape around the extremity that's going to be put in traction, and they hook that up to the traction device. So it has less of a risk of skin breakdown because you don't have a pin going into the bone. Okay. So if you have a kid that's in traction. Sometimes they can be in traction for a long time. So they might be missing school. So there are some long-term things if it's not like 48 hours in traction, if they're going to be in traction for a couple weeks or something like that. So these are a lot of concepts that I think you probably talked about in med surg. So you're always going to be worried about blood perfusion and risk of clots. So they might be, they put the SCDs on, or the foot pumps to help keep the blood flow. They can have tissue breakdown. They're at risk for atelectasis and pneumonia because they can't breathe as much. They can have decreased appetite. They might have urinary retention and constipation, end up at muscle wasting. I think all of these things make sense because, this is just things that you probably talked about in med surg that are associated with prolonged immobility. So some basic things, your nursing checklist for traction, you need to make sure they're in the correct alignment. You never want their head or the bed higher than 20 degrees. Their feet should not be resting on the bed. You want to do range of motion for the extremity that's not in traction. Think about doing anti-embolism. Not having clots form. The neurovascular checks, you will definitely be seeing questions on neurovascular checks and what you're looking for. Skin integrity, make sure they have good pain control. You're going to have to be thinking about preventing constipation, and if they're old enough to have a trapeze so that they can reposition themselves. Okay. Let's see here. So there is an infection of the bones that kids can get that's called osteomyelitis. It's most common in younger children, and then again between the ages of 5 and 14. It's usually in the long bones, and it can be quite painful. It's like I said, it's an infection in the bone marrow, and it's usually bacterial. So common organisms are going to be Staphylococcus and Haemophilus influenza. And sometimes they'll have like a local injury to that bone or even a fracture, and then later they develop the osteomyelitis. So it can be quite complicated. It can result in necrosis in part of the bone. It can be very painful with inflammation, and they can end up with muscle spasms and decreased range of motion. It involves a pretty involved diagnostic workup. The ESR is the erythrocyte sedimentation rate. It is a way to measure inflammation, like systemic inflammation. And they might also do a CRP, or a C-reactive protein. So one of the main things to remember as a nurse is that it takes a long time to treat. So several weeks, around 6 weeks of therapy. So they almost always get a PICC line, and then they go home on the hospital and it's 6 weeks of IV therapy. So they're going to be on antibiotics for many, many weeks. So one of the things that you will see when you're working in pediatrics is, kids that are born with conditions, or they have a genetic predisposition to conditions that present in childhood. So one of those is going to be Duchenne's muscular dystrophy. There's 2 types of muscular dystrophy, Duchenne's and then Becker's. Becker's is a little bit less severe, but they generally involve the same things in terms of it starts with lower body weakness, problems walking and falling and stuff like that. They tend to be clumsy kids. This picture here is of Gower's maneuver. So the kid is unable to get up, and that's kind of what it looks like. He doesn't have the muscle strength to stand up once he's gotten down on the floor. And they can also have some intellectual impairment, although that's not common. It's not 100% of the time. So it also has a pretty marked evaluation. They can have an increase in the creatinine phosphokinase level. They almost always do a muscle biopsy, an EMG and an ECG, and genetic testing. And the main thing to know about muscular dystrophy is that it's progressive. So they're usually diagnosed before their school age, sometime around age 3 to 5, and it just gets progressively worse over time. So they almost always die of like cardiac problem. Their a setup for cardiomyopathies or respiratory infections. So they can't breathe effectively because they just have that progressive muscle weakness. Sometimes they're trached and on home ventilators, and there's no cure. So it's supportive care, giving them the adaptive devices to move around, the cardiac and respiratory support. Obviously, they can be depressed because they know what's going on, even though there's some element of intellectual impairment. They're able to talk and have conversations, and they're being aware of what's around them. So they're not able to compete with their peers. They're not able to do the things that other kids do. So that leads to depression. So it's quite common to get like a social work and a psychology consult. So that is a condition that's genetic that kids develop because of a specific genetic problem. There's this slept femoral capital epiphysis is not. This is something where it's displacement of the head of the femur, and it's just something that happens spontaneously. It normally occurs during growth spurts, and it causes pain, and they can't bear weight on the involved leg. And they can end up being put into traction to kind of pull the femur back into place. So it's not because of an injury. So a couple things to remember about this is that it's spontaneous during a growth spurt. It's not because they fell and hurt themselves. It just happens when they're growing, and it's usually treated with with traction. And there's something else that is a neural or a muscular bone condition of children called leg calf Perthes disease. So you have disruption of blood supply to the epiphysis, and this is that section of the bone that's responsible for the growth, and it can cause tissue death. And it frequently affects the head of the femur, which is the area of the femur that is responsible for growing. It almost always resolves spontaneously, but they can have permanent distortion of the femur head because it causes decreased blood supply to that section of the femur. So they can have problems long-term over time. They can have pain in that site. And because of the distortion of the femur head, it can cause them to have problems as in adulthood. Even though they can have problems later in life, it almost always spontaneously goes away. So it's something that's a little bit tricky because it almost always spontaneously goes away, but at the same time, they can have problems later in life and end up needing a hip joint replacement because of that problem, the lack of blood flow to the head of the femur. But during adolescence, they almost always resolve spontaneously, get on with their life, and then they'll need that hip replacement surgery as adults. So osteosarcoma is cancer of the bone. It's the malignant tumor of the long bones, and the most common age of onset is 10 to 15 years. It is responsive to radiation therapy, but if there is metastasis, which is spread of the cancer to other parts of the body, then it has a bad prognosis, and the lungs are the primary place that it metastasizes to. So diagnosis is confirmed with biopsy. They can have pain and swelling at the site. Sometimes they can have fractures at the site. Sometimes they will end up removing part of the leg where the tumor is. And if you heard of phantom pain, that's where the pain that you have even after the limb has been removed. And then Ewing sarcoma is another form of bone cancer. This one is more responsive to radiation therapy and chemotherapy than the osteosarcoma. So the Ewing's is more responsive to chemo and radiation and is less likely to require amputation. But it's the same thing when there is metastasis, then it's a bad prognosis, and it usually goes to the lungs. Another condition that you can see in kids is something called juvenile idiopathic arthritis. It used to be called juvenile rheumatoid arthritis. You might also see it as JRA. So we think of arthritis as being like an adult problem. This is like an autoimmune problem in kids. So it involves the joints and the connective tissue, and it's very painful. They can have fevers that are very high. It usually comes and goes. It kind of waxes and wanes. It's an autoimmune disorder that has exacerbations and then it gets better. And it's divided into different subsets. So systemic or acute febrile. So if they have a really high fever and they're having joint pain, you're going to think it's a systemic. Polyarticular is more than 4 joints involved, and power articular is less than 4. So you do need to remember this diagnosis in children, and to be aware that it's autoimmune. You treat it, with warm packs, you treat the fevers. They might end up getting steroids to kind of tamper down their immune system when they're having a flare up. And it's not that uncommon to get really high fevers and also have abdominal pain and vomiting with it. So this is the breaking down the different types here. We talked about that briefly. So next we're going to talk about scoliosis. So scoliosis is the curvature of the spine. This one here is the scoliosis here. And it's more common than in girls than in boys. You normally screen for it in an outpatient center by having the girls stand in front of you and they lift their shirt up and they kind of lean towards their feet. And you're looking for this S-shaped curve of their spine. So there's 2 types. Functional is just caused by bad posture, and then structural is caused by a problem in their vertebrae or their thorax. And there sometimes, in this picture, you can kind of see it can cause also problems in their hips and their shoulders. So, if it's just caused by bad posture, you can do some corrective measures in terms of the postures. If they break it down in terms of the degree of curvature. So up to 20 degrees, they would do physical therapy to increase muscle tone and posture. 20 to 40 degrees, they would require a brace. And then greater than 40, they would have what's called a spinal fusion surgery. So, I would kind of remember the breakdown: less than 20, 20 to 40, and then greater than 40, with greater than 40 needing surgery and 20 to 40 wearing a brace to help correct the curve of their spine. So kids can obviously have sports injuries. They're out playing sports a lot. So, one of the things you do as a nurse, always talk about like using protective equipment, etc. We talked about the different sorts of soft tissue injuries, being able to differentiate between just like a basic soft tissue injury and a fracture. So being aware of that, helping parents understand how to treat it, remember the RICE, rest, ice, compression, elevation. Think about which sports are most likely to result in injury. Things like wrestling and football are going to be more than like swimming. So unfortunately, we talked a little bit briefly about child abuse in the last section when we talked about shaken baby syndrome. So certainly kids that present with bruises that don't make sense, or injuries where the story for how they got the injury doesn't really make sense, you need to be thinking about domestic violence or abuse. So what can someone tell me? Like, what are some things that you would see in a kid that you were worried about abuse? What might you see? Have you ever talked about this before? What do you think? If they have bruises, are they all the same age, or are there bruises that are different ages? How would you tell how old a bruise is? I think you know, Erica. Huh?
Color.
By the color. So you do want to be paying attention. They kind of get like that greenish color around day 6. So if you see a kid and they've got multiple bruises and they're different colors, then you would be more concerned about abuse, because this would be multiple injuries that took place over time that had caused bruises to be different colors. So, there's different things that kind of make child abuse more likely to happen. Social stress in the family, parental stress, triggers, not having access to food, the parents having a substance problem, financial problems. Also, children that are disabled or they have behavioral problems are more likely to be abused, and so are foster children and stepchildren. And, abuse can be broken down into different categories: emotional, sexual, physical, and then there's also just neglect when they're not like being hurt, but they're still not getting their needs met. And you are a mandatory reporter as a nurse. So make sure you know your state laws, but all states require nurses to report suspicion of child abuse. So, know your specific, like I said, know your state rules, know what your hospital policies are. If you, report them to an agency, you should tell the parents. And then, depending on the state, but it should be a home visit should be initiated within 48 hours. If the situation is potentially life-threatening, and 72 others otherwise, you got to make sure that your kid's always in a safe environment. So if they come into the hospital, you got to move them away from the parents if possible, so you can talk to them alone. And to remember that you're a mandatory reporter. So there's certain things we talked about: the bruising. So retinal hemorrhages, blood spots in the eye. We talked about that with the shaken baby syndrome. Failure to thrive, different bruises throughout the body, irritation of the genital area. So always, be on the lookout. Don't assume just because somebody is, wealthy or drives a nice car or is really educated or whatever, that they can't be abusing their child. It happens in all social classes. And always believe a child if they say anything to you about being abused. And this is here kind of showing you, how the bruising progresses over time. So, that green color, 5 to 7 days, but it goes from swollen and tender to red and purple to green, yellow, brown, and just recognizing that if they have different bruises in different stages of healing, that is one of the main indicators of abuse. Even though you always want to be aware of child abuse, you also need to be aware that there are certain cultural practices that can be interpreted as a physical abuse, but it's not. There's something called cupping, which is like a folklore treatment to try to cure illness. And they could end up with like marks all over their back where they put the cups. It's like a folk treatment. So just to know that and be aware if you are practicing in a community where different folk healing practices are being practiced by your patients, but you still want to document everything correctly, and make sure that you know how to get in touch with Child Protective Services. So that was the nit and gritty. Like I said, there's a lot of information in there, but I did touch on everything that I know that you need to know. So now I'm going to pull up your Kahoot really quick, and then I'll let you guys go. Let me move this over here. Oh, you guys are going to see my email. All righty. So Danielle, Brittany, can you guys go ahead and join? Come on. So Danielle, your camera is not on and you haven't joined. Can you tell me what's going on? Thank you, Danielle. Okay. All righty. Are you coming back from taking the test, Danielle?
Yes.
Okay. Thank you, Sonia. All right, we're going to go ahead and get started here. All right. What intervention will the nurse caring for a child in buckskin traction implement? Assist the child to be pulled up in bed, maintain the child's feet against the foot of the bed, keep the child's heel on the bed surface, or keep the child in the high Fowler's position. So good job. Yeah, they're going to need help being moved up. You don't want that leg that's in traction resting on anything, and they should never be in high Fowler's. It's a maximum of 20 degrees for their bed. So what is a normal capillary refill? 4 seconds, 6 seconds, 5 seconds, or 3 seconds? So it is 3 seconds. So if it should be 3 seconds or less, 2 to 3 seconds. So this is one of the things that you're doing on your neurovascular checks, especially when they're in traction. You're assessing their cap refill, make sure they have good perfusion in that extremity. What finding would the nurse assessing the neurovascular status of a child in wrestle traction report immediately? Cap refill less than 3 seconds, ability to wiggle toes, skin that's warm to the touch, or bluish coloration of the skin. Right, so you would be concerned about bluish coloration in the skin. Warm to the touch is okay. That's an indication of good perfusion. Cap refill less than 3 seconds is normal, and you want them to be able to move their toes. But you worry about perfusion, cold skin, delayed cap refill, not being able to move the toes. Which observation would lead the nurse to consider child abuse when a child is being evaluated after falling down the stairs? The mother is very anxious. The child has red, green, and yellow bruises on his body. The child broke his arm last year, and for the mother, he's accident prone, or he has bruises on his head, arms, and legs. Yeah, so he fell down the stairs, so he might have bruises all over his body, but you're more worried if the bruises are varying different colors, right? Because that's going to be more than one injury that caused bruises to have those different colors. What would the nurse consider an abnormal finding on a musculoskeletal assessment of a 4-year-old? Appears to have flat feet, walks on his toes, swings arms when walking, or has inward turned knees when standing. So this is the walks on his toes. We talked about this a couple of times. This is an indication of cerebral palsy. So you do need to be concerned if you see a kid age 4 that's toe walking. What nursing action would significantly decrease the risk of serious complication for a child in Bryant's traction? The child's buttocks are resting on the bed. Neurovascular checks are done frequently. The bandages are wrapped tightly, or the child is restrained and unable to wiggle or move. Right. So doing the neurovascular checks is the most important thing. And then the buttocks are not, they should not be resting on the bed. When Bryant's traction is the kid with their legs straight up in the air under 30 pounds. Their buttocks should be lifted up off the bed. A nurse cares for a child in Buck's traction. Which observation requires immediate intervention? Ropes are on pulleys, head of the bed is 20 degrees, child's heels are placed firmly against the foot of the bed, or the weights are hanging freely. Good job. Yeah, you don't want the heels resting against the foot of the bed. Nice. So a child with juvenile rheumatoid arthritis has swollen knees and ankles at temp of 38.8 and abdominal pain. What type of juvenile arthritis is this? Common, systemic, chronic, or psoriatic? So it is systemic. So you think about, in terms of systemic, also called acute febrile, this is this high fever. It's not just the joints that involved, it also involves abdominal pain and high fever, systemic being throughout the body. So true or false? Bryant's traction is reserved for children who weigh less than 30 pounds. Yeah, that's true. That's the little kid one where their legs are up in the air. All right, good job, you guys. Oh, I'm sorry, I added one. What should the nurse include in a parent education about leg calf Perthes disease? Degenerative arthritis may develop later in life. The disease is self-limited and requires no long-term treatment. There are no long-term effects, or there's a risk of osteogenic sarcoma in adulthood. So I understand why you chose this one, because I talked about problems later in life, but specifically later in life, they might have degenerative arthritis and may end up needing a hip replacement therapy. All right, here's our podium. Woohoo! All right, good job. So I want to, I'm gonna go ahead and close this down. I just want to say something in terms of studying for the test. So I've tried to go through on the Kahoots and like pull out topics that I know will be on the test, but I haven't given you the question. So, if I put juvenile arthritis on the Kahoot, then I know that there's going to be at least one question on juvenile arthritis on the test, but it won't be the same question. So I just want you guys to be aware that I'm trying to help you out and trying to steer you in the right direction, because I know there's a lot of information. So I'm just going to say that I'm not ever going to give you the test questions, but I pick ideas or concepts that I know you'll see again. And I strongly encourage you to come to one of the review sessions, and I'll post the review sessions, the recording of it in class. And if you have any questions about the test, you can schedule an appointment with me. It's about time to go. Does anyone have any questions or anything they want to ask before we wrap up class today? All right. Thank you guys for joining, participating, doing the Kahoots, and let me know if you need anything. And I hope to see you in a review session this weekend. Bye-bye.